hasn't changed yet. You okay?
Sure. Am I live now? Good evening, Naval Information Forces. I am coming to you live from NAVIFOR headquarters over here in Suffolk, Virginia. Thank you very much for taking time out of your busy lives and an evening that you're probably spending with your families to spend a little time with me. By way of introduction, for those of you who don't know who I am or what my background is so far, I am an OBGYN by trade, so I've spent my career taking care of women and their families, peripherally. And it's been my extreme honor and privilege to be working for Information Forces since approximately June of last year. So the reason that we decided to do this Facebook live stream town hall was to address directly and in a group format some of the questions that you all have had that have been coming into my email, via my phone lines, etc. And so my thought process was that if I could take a little bit of time in a group with you all and answer questions that most of you probably share, that I could get answers and information out to the best of my ability to you as a group moving forward. This seemed to be pretty well received and busy last week when we did it during work hours, but I know there were a lot of folks who were unable to dial in because of network restrictions, and so hence tonight's offering. I will do the best I can to answer your questions. I will speak based on what I know to be true, which may or may not be consistent with what some of you are seeing on the internet and on the news. And for those of you who gave me homework last time, and what I mean by that is questions that I just didn't have the answer to, I was able to research all of them, and I was able to post the answers on the Facebook thread. So please feel free to let your friends know if you know they posted a question before, that they can just get right on and find that answer. So while we're waiting for questions to come through, and if you have questions, please go ahead and post them so that I can be answering them as we move ahead tonight. What I thought I would do is start with a topic that has become really near and dear to my heart, and that's mental wellness, mental health and wellness. And I've gotten a lot of questions over the last couple of weeks, specifically regarding stress and how do we handle the stress of dealing with what we're going through right now, which has pretty much resulted in a complete disruption of how we handle both our professional and our personal lives. Many of us are teleworking and are experiencing isolation and disruption in our normal routines, which makes it more challenging to deliver good work product. Others of us are sitting at home with our kids, and now we're having to homeschool our kids in addition to get our work done, and that adds another layer of stress. For those of you that are also at home with your spouse teleworking, I don't have to tell you that that adds even another layer of stress. And so we have both external stressors, right, this disease and the stop work or the stop movement restrictions that have been put on us, as well as our internal stressors, things that we kind of put on ourselves, like high expectations for work product, for our performance as a parent, as a spouse, as a colleague and a coworker, as a friend. And all of that can cause us to feel more levels of stress than we're typically used to. And so one of the things that we could all do is practice self-monitoring, which is where you sort of start paying attention to your reactions to normal situations. So all of us, when we're in certain situations, we have responses. Some of them are emotionally appropriate. Some of them are way out of proportion. So some of us call that flying off the handle. Somebody asks you a simple question or asks you to do something small, and it may be just the wrong thing to ask at just the wrong moment, and that causes a disproportionately emotional response. So what I would ask all of us to do is to develop sort of an internal monitor where we say, okay, how did I handle that situation? Was it appropriate? Was it not appropriate? Do I need to take some time out? Maybe I need to go exercise. Maybe I need to go meditate. Maybe I need to go have a good meal. It's been 8 hours since I've eaten. I just totally forgot about food. Maybe I need to have a conversation with my significant other or my kids about new boundaries and new expectations given this new way of doing business for the last couple weeks. And then if you find yourself kind of unable to self-regulate or it's becoming a lot more challenging, please know that there are so many resources that are available for you to reach out to. Some of them are available online. Some of them are available at Fleet and Family Services Centers. They've got some amazing licensed clinical social workers there that can be a really good sounding board. We also have amazing mental health providers located both in the clinics, online, via Military OneSource, and at our hospitals that are still taking care of us. If you have any questions about any of those, please reach out to me and I can point you in the right direction. Are we waiting for questions to come in? Okay, so what I'll do while we're waiting for those questions to come in this evening is I will specifically address some of the interesting questions that I maybe didn't have the answers to prior. One of the questions I was asked was, hey, if I wash my uniform and I do it on the sterilized setting, is that enough to kill the virus? And so as it turns out, that virus can be killed with 15 minutes or more of exposure to dry heat that's at least 56 degrees Celsius, which translates to about 132, 133 degrees Fahrenheit. Most of our dryers, both for preheat and for regular drying, will heat at least that temp, if not higher. And so I would recommend that you just check your personal dryer settings to see whether or not that is adequate. But I think for most of you it will be. A related question that I got was, hey, will steaming my face work to help kill the virus? That's a little bit of a trickier question. So steam, as it comes right off of a boiling pot of water, is at least 212 degrees. And that is enough also to burn your face, as it turns out, or anything else it comes in contact with. So typically, a steaming technique involves tenting, your face over a pot of hot water so that that steam can get into your nasal cavities and into your throat to help soothe symptomatically a sore throat or to help with allergy control. In this particular case, I would say, I don't know how hot that steam or that hot air is going to be by the time it actually hits your nasal cavities. So hopefully it's not going to be as hot as it would need to be to kill that virus, because that's also hot enough to potentially burn your skin. So it's a little bit of a twofold answer for you there, but that's what I discovered when I did my research. Another question that I was asked is the Navy system right now soliciting blood donations from people who have very specifically been tested positive for COVID and then have had the appropriate negative testing to follow on? And what I found out was, at least at our local level, that the Navy facilities that have a blood bank, they get their blood from the Armed Services Blood Program. That program right now is not actively soliciting nor using plasma-rich, antibody-rich blood products to treat COVID patients, which is why that's being used. The theory is that people who have had the virus, have developed antibodies, now will have plasma that is antibody-rich that can be utilized to specifically treat those that are sickest among us. We are not specifically soliciting for those blood products right now within the military system, but all of the surgeons general have expressed an interest in investigating how we might make that happen. And so I don't have a date for you or a plan, but I know it's being discussed in any event.
Well, we have one question. Jackie asked two questions. One is, if all I have available at the time is hand lotion, does that provide any protection from the virus? And conversely, hand sanitizer dries the hands out. So if you apply lotion, does that negate the hand sanitizer from working properly?
So the first question regarding hand sanitizers, no, that does not confer any protective benefit against the virus. It does not clean your hands at all. As to the second question, yeah, hand sanitizer being 60% alcohol is very drying. And so as long as you are applying the hand sanitizer, leaving it on for at least 20 seconds, you can then apply lotion after that point to help protect your skin from drying out, and you will still get the sanitizing benefit of using that product on your hands as an antiviral.
All right, Mark has a question. It says, I grew up in Europe in the 80s and was told I can't donate blood due to the risk of mad cow disease. I have a rare blood type. Is this still the case?
Wow, I think now I have homework to do again. So a lot of that is going to depend on what the current guidelines here in the United States are from the American Academy of Blood Banks regarding that very particular disease. So Mark, what I'm going to do is I'm going to take note and I am going to find that information out for you, and I will post it to this Facebook feed in the comments section before close of business this week. Thank you for that. That was a really great question. Okay. So another question that was asked last week, which I didn't know the answer to at the time and had to do a little research, was why is VBSS training still occurring? So VBSS is Visit Board Search and Seizure, which I learned a little something. I didn't know that beforehand. And VBSS training is being conducted at Little Creek. And the concern was these sailors are participating in this training, and is that safe during COVID when we know it's spread by contact and potentially respiratory droplets? And so I know that there have been a lot of exercises and training events and other events that have been canceled, including some that are mission specific, based on concerns for spread of this virus. If this training is still ongoing, I would hazard an educated guess that it is mission essential, and that is a discussion that is ongoing and dynamic, and it's all about the risk commission versus the risk to our personnel. And given the fact that they are wearing masks, even though I know that sometimes those masks come off, given the nature of this training, I can guarantee you that commanders are having that discussion almost on a daily basis moving forward, because all of us understand that our personnel are our most precious resource, and protecting and defending the health of our force is our #1 goal. And so if you are concerned about specific trainings that are ongoing, please feel free to have that open and transparent conversation with your chain of command. And then if you do find that you have concerns that you may or may not feel comfortable addressing, please address them to me, and I can do what I can to do the research.
Well, Doc, Emily said that she had the same question Mark did about donating the blood with the red blood type. So more than one had that question. Christy says, can I recover?
So hold on just a minute, PAO. So I'm going to address the blood donation just for a minute. So right now, I think there are a lot of folks who are afraid to donate blood, but the need for blood products has not gone down in this country. So if you are able to donate blood, especially if you have a rare blood type, please, please, please go to your local blood bank and make that donation. They are in desperate need. I know you all have seen all the advertisements on cable networks and on your local news channels. There's really a big push for blood right now. So like I said, if you are able to donate blood, and especially if you have one of the more rare blood types, please make a date, go to your local blood bank and give some of that precious resource. Thank you very much. Okay, sorry about that. Go ahead.
No, Christy has a question. Can a recovered COVID-19 patient become reinfected with COVID-19 again?
So that's an awesome question. We don't think so, but the bottom line is we're not going to know until we begin doing surveillance testing. So right now it's not clear whether or not having COVID will grant you short-term immunity or long-term immunity or both. And so typically what will happen when you're exposed to one of these viruses is your body will develop immunity. The question is, how long will it last? We used to think that if you had vaccinations to certain diseases, that conferred you with a lifetime immunity. We know that now longer, let me rephrase, we know now that may not be true for every one of the vaccines or every disease that you come in contact with. And so if you ever are in doubt, ask your provider and they can talk to you about being able to test. But the truth is, coronavirus is not a new thing. There are multiple different types of the coronavirus that circulate within our population every year and that are causes of the common cold, as we like to call it. This one is different because it's a new strain. It's a novel strain, and one that we weren't prepared for as a group, as a community, as a world, to fight as efficiently and effectively as we have the others that circulate on an annual basis that our immune systems are used to seeing in some form or flavor. And so that's why this has been a little more challenging. So hopefully that answers your question about immunity.
Steve has a question. He says, I've heard contradictory information on how COVID is spread, and that tests show persistent viral DNA on surfaces long after exposure, but not necessarily reflect live virus. Is there consensus on how COVID-19 is spread and how long the virus is contagious on surfaces?
That is a great question as well, and so the answer is yes. There is consensus on how long it lasts on surfaces, at least certain surfaces which have been studied. So per both the World Health Organization and the Centers for Disease Control here in the United States, we know that the COVID virus can live on cardboard for up to 24 hours, right? It can live in aerosolized particles, so respiratory droplets in the air up to 24 hours, I believe, and then on, I'm sorry, that was wrong, up to 3 hours in the air. I apologize for that. 24 hours on cardboard, 3 hours in the air, and up to 3 days on stainless steel, on plastic surfaces. Now, just because it's still living doesn't mean it's in a huge concentration. So what happens over time is both the strength and the number of those living viral particles diminishes. So if you were, say, to touch a surface immediately after somebody with COVID had touched that surface and deposited particles, you would be a lot more likely to transfer that to your hand than you would be if you came upon that same surface 3 days later. So you would be much less likely to become inoculated or infected at that later date. But it's not impossible that you could be. So those are the consensus for life of the COVID on those several surfaces that I just mentioned.
Cassie has a question. It says, Captain Adriano, we have several sailors transferring this summer, and they're struggling to be able to get the necessary medical and VA appointments for separation.
Yes.
Are there any policies to help with the timeliness or allow sailors to get appointments done after separation?
So the separation, it's going to be, the answer may or may not be different depending on if it's retirement or just separating from your time on active duty. So I know very specifically that for retirement physicals, you're right, it's been very challenging to get in because right now the MTFs are not seeing routine medical care. They're reserving their resources for urgent and emergent medical care. For retirees, getting that screening and that physical exam done before you retire is not a deal breaker. You can still get your retirement taken care of. However, then you will still need to go through the VA to get that screening and paperwork and physical done at a later date to make sure that you get all of your benefits and everything is taken care of from an administrative standpoint. Now, that may result in a delay in you getting any benefits that you would have been eligible for. As for the separation portion of it, and the other question somebody may have out there is, well, what about re-enlistment, right? I mean, you're supposed to be able to get medical signatures and a screen done, if not a full-on physical exam for both of those eventualities. We're working through that right now, so I don't have a hard and fast answer for you. I have reached out to BUMED because this is a question that came up from our headquarters career counselor just last week when we had a conversation, very specifically regarding special duty screenings and then re-enlistment. Now, the special duty screenings, specifically for submarine and air crew, those have been delayed or extended, I should say, by 4 months. But let me see if I can reach back out to BUMED and get a harder, faster answer regarding separation physicals. Thank you. Let me just make a quick note before you read that to me. I'll just have to look at the top of my head for a moment. Okay.
All right, Jackie has a question. It says, I prefer Motrin for the occasional headache, but I've heard on the news that Motrin is not good to take if you have COVID. I don't think I'm infected, but if I'm unknowingly asymptomatic, will it be harmful to take Motrin for a headache?
So I think that question must have come out from a news release that was put out by a group of physicians, which was based on inconclusive and incomplete data. So right now there is no consensus that if you take Motrin and you have COVID, it's going to make anything worse. Matter of fact, intuitively from a medical standpoint, that doesn't really make sense, because what happens when you have a cold or this particular virus or the flu is your body mounts an inflammatory response. That's part of your healing process. Motrin is an anti-inflammatory by its very nature. So unless you have another reason for not taking Motrin, it is not going to hurt you while you have COVID, to the best of our knowledge right now.
Robert has a question, says, does too much stress hurt overall wellness and make us more susceptible to viruses? And if so, what can we do to prevent that?
So that's a really loaded question, right? Because there's good stress and there's bad stress. So the bad stress, all of that is how you internalize it, interpret it, and then kind of deal with it. So any kind of stress that you have causes certain biochemicals within your body to be released. And then how your body kind of deals with that from both a physical and a mental and emotional standpoint determines whether you have health benefits or health problems because of that. So right now, kind of where I'm sensing your question is coming from is that there are a lot of people who are expressing that they're having some significant negative stress as a result of the life changes that people have had to make very suddenly, very abruptly, for this dealing with this COVID crisis, and without a clear end point, which in and of itself, uncertainty is a certain stressor in our lives, right? So to get to the next part of your question, which is how can we deal with that, there are certain things you can do on an everyday basis, and we all should be doing as part of our overall health and wellness. Those are really the most basic things. So making sure you have good nutritional intake, right? So instead of eating a bag of chips and a candy corn for comfort, maybe having some carrots or an apple with peanut butter, or a nice healthy sandwich, but something that is going to be a more healthy food choice. Instead of stress eating, which a lot of people do, instead of doing that, maybe when you get a craving for food, have a glass of water, or take yourself out of that situation and go exercise. Exercising actually releases good endorphins, and it doesn't matter how strenuous the exercise is, right? It could be going outside, getting some vitamin D conversion with the nice sunlight that we're starting to enjoy, at least here in Virginia. It can be going out for a run. It could be working out hard, doing your P90X if that's still a thing. It's hard right now because it's hard to get to a gym. They're all closed. So we've all had to be very creative with how we exercise at home. I've had people ask me, well, do I need to wear a mask when I go outside running? The answer is, if you're going to maintain 6 feet of physical distance between you and either A, your running partner, if you're doing that, or B, the people that you're running by on the street, then no, you do not have to wear a mask when you go out running or exercising in public. It's mainly that physical distance that we're looking for. Other things you can do besides exercise, I know it seems like I got a little off on a tangent there, right? But other things that you can be focused on, I mentioned briefly, adequate hydration, right? Taking time out to do things that you already know are stress relievers for you. Some people meditate. Other people take 5 minutes or 10 minutes or a half an hour and read a book that they really enjoy. Sleep is another unsung hero in the fight against negative effects of stress. If you are well rested, you are much better able to deal with little irritants that come your way during the day, or a big life changer like, oh, hey, you're going to be teleworking for the next few weeks. Or a few months, because we really don't know kind of what the endpoint here is going to be based on the number of cases, the plateau, the flattening of the curve, and all of those other decision points that are going to be crucial in making decisions to go back to our normal way of life.
Brandon has a question, says, we have a lot of do-it-yourself masks out there at the moment,
Yep.
many of which I noticed do not create a proper seal to protect the wearer, such as gaps on the neck or on the cheek areas. Can you discuss the proper wear of these do-it-yourself masks?
Yes, I can, but I will also refer you to the CDC website. If you just go to the cdc.gov and type in face masks, a whole couple of pages will come up discussing how to make them, what materials are recommended, how you get a good fit. And the reason I put that in air quotes is that really the good fit is from specially designed masks, such as the N95 or the P95, where healthcare workers, who are the folks that are really, those are designed for, healthcare workers have to actually have a special test, a fit test, where they basically have their head put in what I would say is either a box or a bag. They have a noxious substance blown into that, and as long as they can't smell it, it's a good fit. So none of us have to worry about having a good fit mask for the purposes of what we're wearing them for right now. What you do want is something that effectively covers your nose and your mouth, and that covers you at least out to the sides of your face. None of us are going to have, like I said, an excellent fit there, but that's not the point. What you want are several layers of cloth, and the reason for that is because most of the cloth that you're going to find on the market, the holes in that cloth are larger than the little viral particles that could skinny themselves through. And so that's why the recommendation is for at least 2, if not 3 layers. I had previously recommended that you shouldn't use flannel, at least as the mask itself, because flannel tends to absorb moisture, and that's going to hold those viral particles in place and cause you to be less protective of others as you're out and about. However, if you have a little pocket that you've been able to have some lovely seamstress sew into the middle of your mask, then you can pop a bit of flannel in there as just an extra barrier. Another trick that I saw online, which seems rather genius to me, is the use of a HEPA filter from a vacuum cleaner bag. And so you can cut one of those out if you so desire and pop that into the middle of your little pocket if you have a mask that's made out of cotton. Quilted cotton is a good one to use because it tends to be a little bit thicker. So hopefully that answers your questions about type of cloth that can be utilized and effectiveness.
Carrie has a question. Says, why is it called a disease when people can fully recover from it?
Well, that's a great question too. So most diseases can be recovered from. And I say that as more of a medical as opposed to maybe more of a layperson as opposed to a medical. But there can be both permanent and temporary disease processes that the body goes through. So you can have a permanent disease like diabetes or hypertension that are both curable and treatable. So for some people, if their underlying cause for their diabetes or hypertension is obesity and they lose weight, they may completely get rid of the disease of diabetes and the disease of hypertension simply by modifying one of the risk factors that contributes to that disease. Similarly, when you have a virus, you have a disease, you have COVID because of the underlying virus, but once your body eradicates that virus, you no longer have the disease. Hope that makes sense.
Okay, John has a question. It says, does the Department of the Navy anticipate large-scale antibody tests prior to large-scale return to work from the current schedule? If so, will there be priority for active duty civilians or contractors?
So right now there is no plan that I'm aware of to do that. I do know there is discussion about serology testing, which is very specifically what you're asking for, so that we're able to take a blood sample, whether it's a tiny tube or a tiny finger prick, evaluate that to see whether or not there are the presence of antibodies in your blood as evidence that you now have immunity, right? So you've already had the disease and now you've built up immunity. Right now, there's a lot of discussion and evaluation about the current antibody tests for this specific virus that are on the market. In order to be able to use those effectively, we need to verify that they're accurate. And right now, the discussion that's being had revolves around concerns that they're not as accurate as we would want them to be in order to use them to make these full-scale evaluations and a determination about whether the force as a whole should get back to normal, right? No ROM, no country risks, etc. You know, the Navy is in over 100 countries around the world, and so those tests are not going to be hugely available to the over 1 million people that we have just on active duty working within the Navy, let alone all of the GS and contractors that we have also working for us. So what I can tell you is that that is a discussion that's occurring. I don't know of any viable plan that's been launched to date to make that actually happen.
Following up on the return to work question is, what extra concerns should those who have underlying health issues have with returning to work?
So first of all, if you have underlying health concerns during this COVID pandemic that we're all dealing with, every effort should be made to have you telework, okay? And if you are a healthcare worker, every effort should be made to have you not take care of anybody who may be at risk for COVID. So first of all, if you have an underlying health condition such as a current and ongoing cancer, or you're getting chemotherapy for a cancer, or you have chronic lung disease or cardiac disease, or an autoimmune disorder, or you're over the age of 60, or you fall into that special population of pregnant patients, right? You should be offered every opportunity to telework. If you have not been offered that opportunity, please reach out to me for ways to communicate those concerns to your leadership. As far as when all of this is over, when should you be able to return to work? Once we've determined that the risk to you in the workplace is the same as it was before we had the COVID issue.
Tanya has a question. It says, because not all symptomatic people are being tested and given a positive or negative result, how is this going to affect service members later if it's found that COVID causes certain cancers?
So right now, first of all, there's no evidence that this particular virus is going to be any different than other COVID virus or the other coronaviruses and be an etiology for cancer. Now, I don't have a crystal ball. I cannot look into the future, and I cannot look you in the eye or into the camera and tell you that this is not going to be a virus that causes cancer. What I will tell you is that there are antibodies that will be built up to this in the future. So for those of us who may have a concern that we were diagnosed with COVID, but there was no test done, there will be the option for you all in the future, once we have determined that there is an accurate serology test, for you to go through your medical chain and ask for that test to be done. And again, that is nothing that's going to happen right away. That's probably weeks to months down the road to have an accurate, consistent test. I hope I'm wrong and it's sooner than that. But again, I know what it takes to vet lab tests like that and to make sure that they are accurate, and that it's not a quick fix. That's okay.
So Mark says, I cannot find a good hand sanitizer. Is hydrogen peroxide a good substitute?
Yeah, that's a tricky question. So there is some evidence that hydrogen peroxide has some antibacterial and antiviral effects. But Mark, you've now given me 2 pieces of homework, if you're the same Mark, although I will give you, Mark is a pretty common name. But I will double check on the whole hydrogen peroxide. I can tell you soap and water is effective. I can tell you alcohol is effective. And alcohol is what is in most hand sanitizers that you're going to get. Worst case scenario, if you've got a bottle of isopropyl alcohol at home, you can always use that. Okay, I've got my homework written down.
Diane says, ma'am, says the hospitals have prioritized COVID-19 in emergency cases. What are the non-COVID routine cases supposed to do? Maybe someone with chronic illness or someone that needs surgery that is deemed elective.
So I know that the way that most of the MTFs and clinics have tried to mitigate reducing risk to patients from being in the hospital and reducing risk to healthcare providers from being exposed to COVID is they've gone to a lot of virtual health or telehealth appointments. And I am being told that they are still accommodating as many patients as they can with virtual or telehealth. If you find that you are unable to get in to see your provider via virtual health appointment, please reach out and let me know, and I will see what I can do to accommodate that. I do know that all of the MTFs are absolutely prioritizing active duty. And so for sure, if you happen to be on active duty and you are unable to get in to see somebody or to get accommodated by virtual health, that can't be happening. So I need to know so that I can help smooth those waters and make sure we're ensuring the force of our health of our force. You know what I mean? Oh, and you mentioned about elective surgeries. So surgery is tricky, right? There's elective, which in my mind, as a woman who is a surgeon and operates on women, the word elective is kind of a misnomer because it implies that you don't need it at all. It applies like it's plastic surgery, right? And in my mind, plastic surgery is the only surgery that's truly elective. Otherwise, it's an indicated surgery, like you have an underlying condition and you need a surgical intervention in order to help you fix that underlying condition. So the trick then with what we're going through now is it an urgent indicated surgery? Is it emergent? Or is it not really time dependent, right? And so it's easy for us to say that as an organization moving forward, but it's a lot harder when you're the patient waiting on that surgery with a life condition that's causing you to either have pain because of it or an abnormal, like for me, in the instance of taking care of women, I do a lot of hysterectomies for fibroids that cause women a whole lot of pain and discomfort. For them, it's not elective, it's necessary so they can get their life back. And so this is one of those situations that we're going through as a country where we're having to make decisions that we never really had to make before, right? We've always had the luxury and the time to address these issues at a time that was convenient for the patient, at a time that was convenient for the provider. And we didn't really have to take a whole lot of these external things into consideration. So this is uncharted territory for not only you as a patient, but for us as providers. We don't like to see our patients suffer. We like to be able to intervene in ways that help you feel better and get underlying conditions taken care of. And this is just really a terrible situation we all find ourselves in. And I know that we're going to be working as hard and as fast as we can in a safe manner to get all of these surgeries taken care of as soon as we come out at the end of this tunnel.
Katie has a question. Has there been any guidance put down about suspending periodic evaluations because of the situation right now with COVID?
So I'm assuming by that you mean like evals, fit reps, maybe a car, for those of you who do periodic performance reviews. I don't know the answer to that question. I know that at this level, that I've seen no guidance from either the CMP or from PERS that says there will be any change in the due dates for fit reps, for enlisted evaluations, or even DPMAP for our civilian employees. If I do happen to hear of anything like that, I will let you know.
So here's a question. It says, is it expected when a COVID vaccine is developed that it will be an annual requirement like the flu?
So nobody knows yet, right? I mean, a lot of that's going to depend on how we see this particular virus plateauing, if we're able to flatten the curve, and then checking the whole concept of herd immunity at a later date, and then doing community surveillance to see just how widespread this was. There are some initial reports coming out of China that suggest that there is anywhere between 50 and 80% of the completely asymptomatic patients that they tested were positive for COVID. How that's going to play into a long-term plan for the need for a vaccine or no need for a vaccine, nobody knows right now how that's going to work out. Would it be maybe more like the Pneumovax, where you only vaccinate those people who are in a high-risk category? So Pneumovax is typically reserved for people that are over the age of 65 or who have an underlying condition such as they don't have a spleen anymore and they're really at risk for, that particular disease. They receive that vaccine on an every 5-year basis just to make sure that they're as protected as we can possibly get them, but that's not a vaccine that's recommended for the entire population. So I don't know how any particular vaccine for coronavirus will be decided upon or administered as we move forward. But I am quite sure that it will be talked about on the news and by your medical community. So just stay tuned.
One question is, I heard there are at least 2 strains of COVID. Is that true?
So there are multiple different strains of the COVID or of the coronavirus, and so novel coronavirus refers to the actual virus itself, whereas COVID refers to the kind of the disease process. So as far as there being 2 types of COVID, right now we're calling this COVID-19, partly because we know it started in 2019 and it's COVID. But there are multiple different strains of coronavirus, and as I mentioned earlier, those types of coronavirus circulate throughout our population every year, and they are the source of, for some of us, what we have typically called the common cold, in addition to some other viruses. And so the coronavirus in and of itself is not a new thing. It's not a new thing for our group immunity, our herd immunity. What makes this one different is the fact that it's a mutation, it's a new strain, which happens. with viruses and bacteria on a fairly regular basis.
Joseph says, is there a current estimate on how many people CONUS without symptoms who might be carrying the virus? I am trying to gauge on the threat level while doing routine visits to the grocery and hardware store.
That's another really pertinent question, and the answer is we don't know. We don't know right now how many folks are walking around with absolutely no symptoms and have either already had the virus, have already built an immunity, will never have symptoms, and are no longer contagious. Then there's another group of people who are walking around with no symptoms, who are what I would call pre-symptomatic. So they have been inoculated, they haven't built up, and the virus hasn't replicated itself enough within their system to cause symptoms. And so they are shedding virus, they are contagious, but they're not symptomatic yet, but they will be. And so we are not doing a great job right now of figuring out who those people are, what percentage of the population they are, and the pre-symptomatic folks may or may not be a little easier to track because eventually they're going to have symptoms and they'll be diagnosed, right? It's those asymptomatic people who never will have symptoms that have been exposed, inoculated, infected, and completely get over it because their immune system is doing what our immune systems were built to do. It's making antibodies quickly, it's identifying the threat, it's making them the antibodies to fight it off, and it's gone before you actually have time to register a fever, a cough, shortness of breath, etc. We're not going to know that level until we start doing surveillance testing, and again, that's going to be predicated on having an accurate surveillance test and having a nationwide effort to make that happen. And someone will at some point need to do a risk-benefit analysis to find out in which populations does it make the most sense to focus surveillance testing, and how will that test be administered. Okay, so while we're waiting for some more questions to roll in, I can spend a little more time talking about face masks. Not about how to make them, but just to remind folks they are not a substitute for that 6 feet of physical distancing. And I'm really trying to get us away from using the term social distancing, because what that does is it makes a lot of folks feel even more isolated than they already are, especially those of us who may live alone and are teleworking and who don't have that day-to-day physical interaction with folks. Being able to just look people in the eye and say, hey, how's it going? And have little P-way conversations, right? So physical distancing, because that's really what we're practicing. It's been kind of fun to take walks in my neighborhood and watch how people are practicing physical distancing. There's a couple families in our neighborhood that have a Friday night wine club, right? And so they are sitting out on their driveways, and they are not in any way close to each other, and they are still having social hour. They're still chatting with each other, but maintaining that physical distance and not wearing face masks because, you know, they're separated by a driveway or two. So there are ways to continue to interact and to have fun with each other without getting really close. When you want to wear that face mask is when you're maybe going to be going to the hardware store and it's a little bit crowded and you don't feel like you can maintain that 6 feet of physical distancing, or when you go to the commissary and you get there at 7 a.m. for the early bird special and you're, you know, standing in line with folks. If you feel like you can't maintain that 6 feet, absolutely put that mask on. And again, that's more to protect others from the possibility that you may be shedding virus and not even know it than it is to protect others, although it ends up being a little bit of a two-way street.
Robert asks, is there any knowledge yet as to why males and African Americans in the U.S. are reported to have more severe COVID-19 illnesses than females or other nationalities?
So the short answer is no, but there are some suspicions. And so African American and male, when you put that together, overall, that demographic in our country tends to live in poorer neighborhoods. They tend to live in more crowded, poorer neighborhoods. They tend not to have access to the same health care that many Americans have access to. And so remember when I was saying before that there are some basic things you can do to protect yourself overall. Those things are sleep, those things are adequate nutrition, and the impoverished and poor among us tend to be malnourished. They tend to not eat as healthfully. They're not drinking as much water as they should. They're not sleeping as well. And they have a whole different level of stress in their lives that many of us don't have. There's also a suspicion that because they don't seek and or have access to the same health care that many other Americans do, that they may have underlying or pre-existing conditions that they don't even know about, right? So they may have high blood pressure, they may have diabetes, they may have an underlying cancer that they're completely unaware of. That also makes them more susceptible to having complications from COVID. And I think that's what we're seeing, is that this particular demographic, African Americans, and I think that's all comers, not just men, tends to have a worse outcome overall. It's interesting you mentioned men. So there's some data that's come out of both Italy and China that suggests that men are dying of, when they are diagnosed with COVID, they're dying at higher rates than the women are that are, diagnosed with COVID. And there are two suppositions that have been put forth thus far as to why this might be. Number one, the men in those countries are much more likely to be smokers. In China, for instance, more than half of the adult male populace smoke, and they smoke heavily. In Italy, it's very close to that number, especially in that older population. A lot of older Italian men are much more likely to be heavy smokers and to be smokers for their lifetime. And the other sad truth is that, wait for it, men, you do not wash your hands as much as we women do, all right? So part of the way we're combating this right now on the streets, all of us, is hand washing, hand washing, hand washing. Before and after you prepare food, for sure after you go to the bathroom, right? If you do happen to shake hands or you've touched some surfaces and you're just not really sure about them, wash your hands. Use hand sanitizer liberally throughout the day. Those are the things that we're going to be able to do that are going to prevent us from having those same outcomes. But hopefully that answers your question about African American population.
Christy says, I've heard discussions of lower numbers in the summer and a resurgence in the fall. Is there any truth to this?
So yes, for much the same reason that the flu surges in the fall and spring and tends to not be as prevalent during the summertime. And there are multiple different reasons for that. One of them is that we tend to be, and this is especially true in colder climates, not as true in warmer climates, but we tend to be much more inside during the winter months, right? So it's colder, plus it's the school year, so a lot of us are inside for that, at all ages, not just our kids and our college-age kids. So number one, we're inside a lot more during the winter months, and so much more of an opportunity in close quarters to spread that disease. Number two, what happens during the summer is we all go outside more, and we know that ultraviolet light, even though it's kind of been broken up a little bit by the ozone layer, there definitely is some antiviral activity that we benefit from UV light. And of course, we rotate closer to the sun during the summer, so regardless of where you're at, you're going to be getting more UV light.
Joseph says, it is difficult to do workouts in my home. Is there any guidance on safety measures while using running paths or working out outdoors? Or should I avoid outdoor exercise altogether?
I would not avoid exercise outside altogether, especially for those of us who that's our stress reliever, right? It's just not the same when you run on a treadmill, and some of us don't have a treadmill because, hey, we're used to running outside. So my guidance for you is, if you're a lone runner, just make sure that as you're running by those slow walkers or those dog walkers, give them a wide berth, at least 6 feet. If you run with a partner, just make sure you run 6 feet away from your partner so that you can be maintaining that 6 feet of physical separation. But I would not recommend that you give up your outdoor exercise routine during all of this. Absolutely pursue it. Enjoy it.
Tanya asks, if you've already had the virus and have been cleared by medical, what is the benefit of wearing a mask?
Well, that's a great question. And if you've already had the virus and been cleared, we're making the assumption that you have built up immunities and you are no longer contagious. Both of those things are true. A, you've built up immunities, and B, you're no longer contagious. Right now, that's based on our best medical evidence. So the short answer is you don't have to wear a mask again. The long answer is sometimes it makes people nervous if you're the only one in the store without the mask on. So again, use your best judgment. If you feel like you can maintain that 6 feet of distance, then don't worry about necessarily wearing that mask. And if people challenge you on it, feel free to say, I would be, but I've already been diagnosed with COVID and I've recovered, so I'm no longer contagious.
Bob says, when would it be safe to interact with someone who tested COVID-19 positive post-systematically, yet can't get the 2 sequential negative tests Navy medicine requires as a return to work criteria?
That is like the best question of the day, and I'll tell you why. I've had at least 3 or 4 cases just today where that has very specifically come up. So right now, the guidance that I have from my BUMED contact, as well as from the infectious disease expert at the Naval Medical Center Portsmouth, is for right now, because it's almost impossible. If you've had a test, a lab test, and you've been told the lab test says you are positive, it's been almost impossible for people to return to the medical clinic and get 2 more, let alone 2 tests. They can't even get 1 to determine that they're negative. And we're going to see more and more of an issue with that as more and more people have been tested with the lab test. There aren't going to be enough lab tests to test people twice. So for right now, the guidance is, even whether you've been diagnosed with COVID-19 with a lab test, or your doctor has clinical suspicion and you have symptoms and they have said, hey, we think you have COVID, we're going to treat you as if you have COVID. Both of those patient populations will follow the non-tested algorithm for going back to work. If anybody has any questions about that, please reach out to me separately via email or phone, and I will be happy to clarify that. But just to say it again, whether or not you've had the test, the FDA-approved lab test, or whether you haven't had the test but have still been diagnosed with COVID based on your symptoms and clinical suspicion, everybody follows the return to work policy for those who have not had a test. And that's hot off the presses. It will be official in writing very soon.
About 10 minutes.
Okay. So we have about 10 minutes left, my handlers are telling me. So if you have any other questions that you feel like haven't been adequately addressed thus far in our chat today, now's your time to send them in so that I can address them. And for those of you who weren't already aware and have access to the NAVIFOR portal page, I established on the For Surgeon page that you can access on the NAVIFOR page an Ask the Doc button, so that if you have any questions, even if it's not specifically related to COVID, if there's something else going on, you're just kind of questioning, please, you can use that medium to send me a communication. It's anonymous, and then I can answer you both privately, and if I think it's a kind of a question that more people might have, I will paraphrase you, and then I will post your question and answer so that other people can also benefit from that knowledge. But that's another good avenue for you to use if you don't have direct access to me via email. I really hate a pregnant silence, says the OBGYN. I'm trying to think of any other specific topics that have come up repetitively that I could just kind of speak extemporaneously on. But you guys have done a really good job of asking me most of the questions so far that have come up.
Elizabeth asks, are there any plans or consideration for commercial type sanitation in any of our spaces, buildings, ships?
I am going to surmise what you mean by that is to have a commercial company come in and do some kind of special deep clean. If I'm not correct, please enter comments real quick and say, no, you're way off. This is what I actually meant to ask you. But in the meantime, I'm going to address that question. So most of us have cleaning crews that come through that are using the appropriate types of disinfectant in order to make sure that we are cleared within our spaces. I know our cleaning crew that comes through on a daily basis and goes through all of our spaces are wearing masks, they're wearing gloves to help prevent them inadvertently spreading this virus in a manner that could potentially contaminate the entire building. As an example of a situation that happened that caused me to kind of think, what would we do if I thought our building was grossly contaminated? So for instance, we had a facility in which the sanitation worker who had been throughout the entire building tested positive for COVID. And this was before everybody was wearing masks and gloves to do clean, to be in the entire building. And so this is several weeks ago. What ended up happening for that building was they were able to contract with a cleaning company out in town that does commercial cleaning. That company came in and did a deep clean of that entire facility, and then all the workers were able to come back into the facility. In theory, that can happen within 48 hours. So the cleaning recommendations per the CDC are, if when you have a contamination, that you allow 24 hours for good airflow throughout the building. And then after that 24 hours, you do good cleaning with soap and water, and then disinfectant with the recommended disinfectant materials. Once you've done that, there's no more waiting period. You have done the deep clean, and your crew is able to go back and re-inhabit the building. There is no plan to grossly decontaminate every building that we work in, and partly it's a risk-benefit discussion, right? We know that COVID is only going to last on certain surfaces for X number of hours or days. Even if you didn't deep clean everything, in theory, if you just walked out of the building and didn't come back for 3 to 4 days, it would be safe to re-enter that building because there would be no viable virus left alive on those surfaces in order to cause a future problem. So hopefully that addressed your question. I didn't hear that you commented that I wasn't on the right track, so I'm hoping that I answered you appropriately.
Yes, we have a few more in the minutes that we have. Robert asks, is there any ability to test all sailors on board ships and subs before they get underway to prevent COVID-19 outbreaks while underway?
So sadly, not consistently, and the reason for that is because the test that we have that we're utilizing right now is not 100% accurate for a negative person. So you could have been infected, you could have be kind of working on that viral ramp-up stage where the testing that we do isn't sensitive enough to pick up that really low viral load that you have. And so we could have a false assurance that sailors that are getting on the boats or the ships, just because they tested negative, that means they couldn't possibly have the virus, and that's just not an accurate, it's not an accurate assessment. So what a lot of folks are doing now is a pre-operational or pre-sequestration, operational sequester, where let's just say, for instance, I knew I was going to have to go to an area that's maybe at risk, and I'm coming from an area that's at risk. I would be put into maybe a hotel room, or I'd be told to stay at home so I didn't interact with anybody for a certain number of days, so that with every degree of medical certainty, I would be deemed risk-free or extraordinary low risk to get onto that boat. And so we're trying to look at ways to do that precisely because these tests are not 100% accurate. So right now, the best data on the sensitivity of the test is that it's about 60% accurate. In other words, if you have COVID, it will say you have COVID. But it's about 90% specific, which means that if you don't have it, then the test will say you are negative, which means there's up to a 10% chance that you might say we might say you're negative, but you're really not negative. So hopefully that makes sense.
Okay, Christy asks, can you talk about the transfer to and from pets?
Yeah, I wish I could, but there's not a whole lot that's known about that right now. It looks like potentially cats may or may not be more at risk to be involved in that transfer than dogs, but bottom line is we don't know right now. At first we thought it was, from the China data. We knew there was a bat influence, right? But then when that transferred to the United States, we were pretty sure it was human to human. And then that tiger tested positive in New York, and all bets were off. So right now it's not clear what role your pets may or may not have in either housing it and being a dormant vector or in actually passing the disease. We don't know.
Okay. Yeah, so Carolyn, just trying to get it all together. Says, let's see. She says, can you test both HPV and also test positive for COVID-2? She says, having had bilateral pneumonia C, a positive HPV and high-risk problems and over 65, admitted to ICU isolation. Could condition be COVID-19 also? No vivid test was available in January here.
So I'm assuming all that happened to you in January, and that the HPV was sort of an incidental or historical part of your clinical history. So as far as knowing whether or not you had COVID then, I would say the best way to kind of make our best guess at that would be, what are your risk factors? So had you just traveled to a COVID-19 country, and back then that was pretty much limited to China, and we were just starting to think maybe there might be something going on in Italy and Japan, but we weren't 100% sure. And then what were your symptoms at the time? Sounds like you had pneumonia. I'm sorry that you were so ill. I'm glad you're recovered and out of the hospital now. The HPV, I think, is not related. And so the HPV is a different type of virus that works on a different type of tissue in your body and causes different types of problems. So I would say those two are true, and unrelated, as we say in medicine. And if you want to shoot me an email or get on my Ask the Doc page and give me more specifics, I probably could give you a more specific answer. Sorry about that. I know it was a little vague. All right, I'm being told that it is time for me to wrap things up. Thank you so much, all of you, for your questions and your comments, and for spending time with me. Again, I know that everyone is very busy, and I very much appreciate your time and the opportunity to serve as your force surgeon. Thank you, and have a great evening.